Vipin, you may start, please.
Yes, ma'am. Thank you. So, first of all, good evening, everyone. Myself, Vipin Kumar from Board Professional. Welcome you all to the Searchlight 13th edition with the topic of pregnancy and breast cancer in association with Kenyor, Kalisgaon, Chikasaon, Cochin, Chittagong, Darbhanga, Deoghar Society. We cordially invited you to WB Connect live webinars. Along with this, I introduce Dr. Sujasa Sri Sangeeta. She is a convener. Along with this, she is also secretary from Bimapur Ops and Gynec Society. I am a Palakol, also a laparoscopic and infertility. Over to you, Dr. Sujasa, ma'am.
Yeah, thank you for that kind introduction. I welcome everyone for today's session. It's a great honor to be introducing Dr. Asha Jain, ma'am. Ma'am is currently the director of SMSA Hospital Raipur. She's the medical director, Cancer Prevention and Relief Society, elected member, CG Medical Council, zonal chair, Foxy Food, Drug and Medical Surgical Equipment Committee, West Zone. She's also the executive member of ISCCP.
Recording in progress.
Her previous posts have been, she's been the past president of Raipur Society, past secretary of IMA Raipur, and also the Rotary Club of the same. Ma'am is an academician. She has done her certificate and she's also the instructor in FCCSB OB course. She's done her IOTA certification. She's received training in colposcopy from AV School of Colposcopy, Chennai. So I now request ma'am to please proceed with the
Thank you, Dr. Sujashri. We start today's program. I welcome all the dignitaries here, and we start by invocations of the divine, and then we take the program forward.
Tunda Mahakaya Surya Koti Samaprabha Nirvignam Kuru Me Deva Sarvakaryeshu Sarvada. Vakra
Namaskar. I welcome all of you to this 13th episode of Searchlight. This Searchlight focuses on one topic at a time, and usually it's a topic that I feel as a gynecologist I need to know more about. And if I need to know more about, I assume that everybody needs to know a bit more about it. So this time the Searchlight is going to be on pregnancy and breast cancer. It has two aspects: pregnancy that precedes breast cancer and breast cancer that precedes pregnancy. And we have two speakers who are going to speak on this very important topic, Dr. Sneha ma'am and Dr. Sneha Bhuyar ma'am and Dr. Geeta Nirukonda, who's a surgical oncologist. We have Kannur, Chalisgaon, Chikmagalur, Kovai, Cochin, Chitradurga, Darbhanga and Deoghar societies with us. Everyone has very kindly agreed to join this topic, which is at first go not so easy. Dr. Alpesh Gandhi sir is our chief guest, and most kindly Sampat Kumari ma'am and Dr. Fessy Lewis have agreed to be our guests of honor. Dr. Sneha is the speaker with Dr. Geeta Mekot, Dr. Manon Mani and Dr. Yashwant Pawar as the chairpersons, and Dr. Geeta with Dr. Lohit, Dr. Gracie Thomas and Dr. Lata Ramesh as their chairpersons. We have three experts, that is Dr. Narendra Zope, Dr. Mandar Karambekar and Dr. Suman Mittal, who's a medical oncologist. We have Dr. Arpita Gandhi, Dr. Bhavya, Dr. Sachin Khedkar, Dr. Lokeshwari K, Dr. Prashasti Patil, Dr. Kumudni Jha, Dr. Rajshri Purve, Dr. Rashmi PS, and Dr. Muruga Lakshmi as our panelists. I welcome everyone to this panel. And I don't see Alpesh sir, though I called him. He said I will join in a little time. So I would like to introduce my guests of honor, and we can introduce sir as soon as he joins in. So our first guest of honor, welcome ma'am, is Professor Dr. S. Sampath Kumari ma'am, who's professor and HOD at Sri Muthukumaram Medical College and Hospital. She was the Foxy Vice President in the year 2022, Senate member, Tamil Nadu Dr. MGR Medical University, National Corresponding Editor of Jogi, Founder Secretary, TN Fogg. She is retired Deputy Director, Institute of Obstetrics and Gynae, MMC, President Board of Studies, Obstetrics and Gynae at TN Dr. MGR Medical University, Chairperson Foxy Adolescent Health Committee 2016 to 18, First ICOG Distinguished GC Member Award in 2021, Chairperson Women's Wing IMA Chennai South and IMA National President's Award and IMA TNSB Award 2021. Welcome, ma'am. We would like to hear your thoughts on this webinar.
Thank you.
Alpesh sir has joined in.
Yes.
Thank you, sir.
We finish Alpesh sir. Dr. Asha introduced Dr. Alpesh sir.
Ma'am, I will introduce him now after Dr. Fesi. The chief guest comes. You give your blessings, ma'am. Yes, sir.
After Sampath, before Fesi, I would like to be in between both of them.
No, sir, you be the first.
Okay, sir.
No, Alpesh sir is first then. Dr. Asha, please introduce Dr. Alpesh sir. You had the CV, no? Anyway. Dr. Asha, unmute.
Ma'am, unmute yourself.
Dr. Alpesh sir.
So welcome Dr. Alpesh Gandhi, sir, our modern day Gandhi, which he proved during the COVID epidemic, where he had such a wide approach to women's health, when everyone thought that, what we will do. And he really made everyone work so much during that period. So he was the President Foxy 2020, resource person for Foxy's GCPR on pregnancy with COVID-19, prepared National Registry on pregnancy with COVID-19 infection. He was a resource person to prepare guidelines of establishment of obstetric HDU ICU Government of India, resource person for operation guidelines on obstetric HDU ICU, resource person to prepare Foxy Gestosis GCPR on HDP, resource person for preparing Government of India guidelines on optimizing the cesarean section rate. His book on principles of critical care in obstetrics is available in more than 5,000 world-renowned libraries, translated into Chinese and Spanish. RCOG has awarded him with honorary FRCOG. He has received the Best Society, Best RCH Activities, and Best Publication Award from Foxy. He is convener of one of the most successful.
I think this is enough, I think.
Thank you, sir. Most welcome.
Dr. Asa, first of all, I would like to thank you for inviting me and giving this opportunity to be there with you in this very important webinar. I am also thankful to you for this kind introduction. I'm so happy to see my friends.
Recording stopped.
My
Recording
friends
in progress.
Fesi and Sampath Kumari there as the guest of honor. My high regards to Dr. Sampath and Dr. Fesi Luis. So happy to see the topic of today's webinar, breast cancer and pregnancy. I would say I have covered almost all the topics during my presidency, but I could not discuss much exclusively, I would say, rather on breast cancer and pregnancy. So I'm so happy that you have selected this topic for today's webinar. And I'm so happy to see Dr. Sneha Buyar as the speaker, Dr. Geeta as the speaker for pregnancy and breast cancer. And you are going to moderate a panel on which have breast cancer and pregnancy in common, cases which have breast cancer and pregnancy in common. Particularly for our country, I think this is very important topic because in our country, incidence of breast cancer is relatively very high across the world. We are among the few countries which are having the highest incidence of breast cancer, as well as our country has high risk pregnancy incidences between somewhere between 20 to 25%. At the same time, breast cancer is now, we can found it in early age of women also. So that is why this is very important to discuss this topic. And you are organizing this series. So I'm so happy that this is the Searchlight series. And today we have Kannur, Chikmagalur, Kowai, Cochin, Chitradurga, Darbhanga, and the other society is with us. I am always happy to see so many societies when organizing any event, any academic and social event, particularly in jointly with each other. So this is really a good initiative, a good activity. I hope this webinar will be beneficial to all of us in our routine practice also. And I would like to congratulate President Secretary of all these societies, Foxy affiliated societies, for participating in the common activity in this webinar on pregnancy and breast cancer. I know Dr. Asa Jain since long. I know she is a great academician. She is very dedicated, hardworking, and she has many publications also. So I really would like to congratulate particularly Dr. Asa Jain, Program Director for this, and Convener Dr. Sujayasri for this wonderful and very meaningful activity. And my best wishes to this series and today's webinar. Thank you very much once again for giving me this opportunity. Thank you.
Thank you, sir. Thank you so much for those kind words. Your video went off, so we couldn't really see you most of the time. But thank you very much for saying those words of blessings. I hope whatever you are doing, you will keep a little earphone and listen to what we are saying if possible. And now I request Sampath ma'am to say a few words.
I
Yes, sir.
have to leave because of one emergency. I have joined in between, so please forgive me.
Thank you, sir. Thank you, sir. Thank you, sir.
Thank you. Thank you, sir. Thanks to Dr. Asha for organizing the wonderful Searchlight webinars. That is the 13th series, I think. The topic, so first of all, regards to our Dr. Alpesh sir and my co-host of honor, Dr. Faisal.
Recording in progress.
The topic of pregnancy and breast. Really, it is very nice. See, I think it is around 1 in 3,000 pregnant patients, the incidence being the pregnancy and the breast cancer. And the breast cancer patient becoming pregnant. That I saw in one article, around 4% of the patients, they can go for pregnant, and that too after the chemotherapy completed 1 year. So we can have a good talks about what is pregnancy and breast cancer and pregnancy by Dr. Sneha Buyar and Dr. Geeta, with the chairpersons being Dr. Geeta, Dr. Manonmani, Dr. Ashwant, and Dr. Lata, Dr. Gracie Thomas, and Dr. Lokita. Then the panel discussion by that director, Dr. Asha Jain, and the experts being Dr. Narendra, Dr. Mandar, and Dr. Suman, and the panelists, Dr. Bhavya, Dr. Pita Gandhi, Dr. Kumudini, Dr. Rajshri, Dr. Sachin, Dr. Lokeshwari, Dr. Rashmi, and Dr. Prashanti, and Dr. Murugalakshmi. Dr. Asha, that 8 societies, 6 is with the C and 2 is with the D, I think. All
Yes,
C
ma'am.
societies, Kannur, Cochin, Chikmagalur, Kowai. So it's nice to have C, 6 C's and 2 D's. So I wish all the best for the success of this webinar. And Dr. Sujay, who is the MOC and the coordinator for this. And Asha, I wish you the success in your future. Thank you.
Thank you, ma'am. Thank you so much. Ma'am, we take alphabetically from the Foxy list.
Okay, okay. Oh,
So that's how it is.
nice.
We started with A and now we are touching D.
So with the T only, I am seeing the Searchlight. Okay. Thank you.
Thank you, ma'am. Thank you so much for being here. Now I would introduce Fessy, sir. So Dr. Fessy Lewis, sir, is a professor and HOD Department of Reproductive Medicine and Surgery at Amrita Institute of Medical Sciences, Cochin, Kerala. He was Foxy Vice President 21 to 22. He is an ISA National Executive Member, ICOG Governing Council Member till 23, VP Kerala Chapter IAG, Secretary Kerala Chapter ISA, Reproductive Committee Chairperson KFOG, All India Foxy International Academic Exchange Committee Chairperson 2013 to 15, Secretary.
Okay, madam. Okay, madam. Okay.
Welcome, sir. Welcome, sir.
Okay. Okay. Good evening to all of you. I think it is a privilege to be here in CME, which is organized by none other than Dr. Asha and respected Chief Guest Alpesh Gandhi sir and Samut Kumari madam. I'm happy to be with them for this specific focused webinar on breast cancer. And as Sambat madam was telling, out of the 8 C and D societies given, 2 are from my state. One is my home society, Cochin, and other is Kannur. And also one from neighboring state, Tamil Nadu, Kowe, one from Karnataka. And the importance of breast cancer, as you all know, once somebody in pregnant has got breast cancer, the significance is that not only they will be worried, they need a lot of questions. So a lot of coordinated approach between the different oncology team and gynecologists is needed. And we have got none other than the past breast committee chairperson, Dr. Sneha Buyar, who is here to enlighten us on that topic. And regarding those after breast cancer, once it is diagnosed, I being in a reproductive medicine, we get patients with fertility preservation, and also those who are cured will come for a fertility treatment. So so pregnancy after breast cancer, that also is important. So that also we have got an expert speaker, Dr. Geeta Nerkonda is there, and we have got a case scenarios of breast cancer and pregnancy cases moderated by Asha Jain madam is there, and also we have got expert panels over here. So I think this CME will be giving more and more information regarding how we can treat whether breast cancer and pregnancy or pregnancy with breast cancer and different cases along that. So like this focus CMEs will be always useful, and we look forward to much more like this focus CMEs where we can improve our patient care and which will benefit to 40,000 gynecologists all over India, and which will be useful for the whole patients all over the country. Thank you for organizing this. Wishing all the best for this wonderful webinar. Thank you.
Thank you so much. Thank you. With these words of blessings, Dr. Sampath ma'am and Fessy sir, if you can stay around, it's fine. Or otherwise, if you have other engagements, thank you so much for your blessings. And now we proceed to the scientific session, and we are absolutely on time. I would request Sujeshri to please introduce the chairpersons of our first session.
Yeah, the first chairperson for this session is Dr. Geeta Mekot, ma'am. She's a consultant gynecologist at AKG Memorial Corporation Hospital and Dhanlakshmi Hospital in Kannur. Ma'am is trained in laparoscopy and reproductive medicine from Keele University. She's also the president of Kannur Obstetrics and Gynecological Society and also the president of, I think, the Women IMA wing of the Talasari branch. I hope I got the name right. So welcome, ma'am, to today's session. Next, we have Dr. Manon Mani. Ma'am is the professor and HOD of Coimbatore Medical College Hospital. Ma'am is actually a gold medalist. She has received the Best Outgoing Student Award. She is also the president of Board of Faculties in MGR Medical University. She's also been an expert peer reviewer for an update on managing PCOS in women. She's received multiple awards and she also has a lot of national and international publications to her credit. So welcome to today's session, ma'am. It's great to have you with us today.
Thank you.
Lastly, we have Dr. Yashwant Pawar, sir, who is from the Mauli Hospital and he is from the Chalsgaon Society. So welcome, sir. I request one of you to please introduce the speaker for today, Dr. Sneha, ma'am. If one of you could please do the honors.
Yeah. Thank you, Asha, ma'am, and organizing team for inviting me for this wonderful webinar on breast malignancy and pregnancy. It is my proud privilege to introduce Dr. Sneha Buyar, madam. She's 1 minute. Sorry, in the phone, I am not able to get it properly. Yeah. Madam is practicing obstetrician with 31 years of experience. She has got a signature award in. Excuse me, please. I'm not getting the. Yeah, sorry.
Geeta, would you do it? Geeta,
Yes.
ma'am?
Yes, ma'am. Yeah, please do it now because I'm not getting the slide properly. Sorry for that.
Okay. Good evening and respects to all the distinguished guests on the platform. Thank you sincerely, Dr. Asham Jain, Madam, the Medical Director, CPRS, for the invite. Canro Society, Obedience Society is honored to be associated with this webinar and so many other dignitaries here. This topic, breast cancer and pregnancy, is a very tough, novel, rare topic to be discussed, but very much relevant. We are actually perplexed when we see breast cancer with pregnancy. We are lost. Patient families devastated and they feel everything is gone for a while. Our Sneha madam, such a sweet, humble and soul will surely throw light into this topic and make us all go home with our society, into our societies with crystal clear ideas. I've heard madam before. She's such a nice speaker, such a great speaker.
Dr. Asha, I can share it, but you can't share whether when other participant is sharing, it is coming like that.
I have stopped sharing, ma'am.
Okay, then I will do it.
Geeta, you are going next. First, Dr. Sneha is going. You will go next.
Yeah, that's fine with me because you asked me to do. No. You asked that Geeta, na, sorry. sorry.
Sorry.
So I thought that it is some problem with sharing that you asked me to present. That okay, that's fine. Yeah.
Dr.
So,
Sneha,
very
ma'am,
good
they're
evening.
going for Vice President West Zone this year. That is what I want to tell everyone. So all the viewers, please keep that in mind. And because till the end nobody stays, I want to say I am going for Chairperson for Drug and Medico Surgical Committee. Please nominate me from your society. Thanks a lot. Over to you, Dr. Sneha.
A very good evening to all of you. Can you all see my screen?
Yes.
Yes,
Yeah.
and you can hear me, right?
Yeah.
So a very good evening to all of you, all the respected seniors and dear friends. This is Dr. Sneha Buyar, past committee chairperson of FOXY Breast Committee. And of course, my introduction, me as a hardcore practicing obstetrician since 32 years now, and I'm contesting for Vice President FOXY from West Zone. That though I'm a practicing obstetrician gynecologist, I have been in touch with academics constantly, and I was a governing council member of ICOG even till 23, and of course I have been associated with all the organization. I'm trying to do my bit for every organization. That is what I can talk about, give my introduction. So friends, all of you know that I was breast committee chairperson, and why, as obstetrician gynecologists, why do we have to think about breast? Why do we have to talk about breast? That is what the inhibition we faced initially. And when we took over this committee, so there was absolute confusion that why are we obstetrician discussing this issue? Because if at all the woman has some breast issues, we have to refer her to the surgeon, because breast is a surgeon's domain. That is what the concept was. And then, of course, we have to take lots of efforts to convince people that actually breast is our domain. And why is it so? The evidence being, because by virtue of our practice, we obstetricians are very closely related to the breastfeeding, actual promotion, teaching the techniques and looking after breastfeeding, dealing with the problems associated with breastfeeding, then of course stimulation and inhibition of breastfeeding, the lactation, any conditions of the breast, including some of the endocrinological disorders, maybe some, some lumps which are benign. So women feel comfortable with their gynecologist rather than going to surgeon. That is what was the common observation. At the same time, other hormonal issues may be cyclical mastalgia, non-cyclical mastalgia, may it be some lumps, and maybe, even the breast cancer when we talk about, because it is usually a hormone dependent tumor, the therapy, even the postmenopausal or menopausal hormone therapy, which we call it, and the problems which come to the woman after this. So all this we obstetrician gynecologists have to tackle. And that is why in the United States and even in UK, the obstetrician gynecologists started thinking that it should be our domain. And there, it is now included in the postgraduate curriculum of the students in obs gynae. And we feel that even in India, it should happen. And that is why we have taken this issue. So we have, taken three subjects actually to tackle the breastfeeding promotion, benign breast diseases, and of course the awareness, screening, and early detection of breast cancer. And for this, we have worked for 3 levels. At 3 levels, we have worked sensitizing the Foxians, training the medics, and of course, making awareness in the common public. So we have tried to sensitize the Foxians by, the updating their knowledge by continued medical educations, the ready reckoners and updates coming up, e-newsletter. Also, we tried to train the paramedics and, make awareness in the general public for, through maybe newspapers, articles, radio and TV talks. So friends, why are we discuss here? Because all of you know the breast has always been a symbol of womanhood and ultimate fertility. And may it be the disease or the treatment, that is the surgery, both evoke the fear of mutilation and loss of femininity. And that is why whenever we have any issues related to this, we have to think a lot and then act. So the topic precisely is breast cancer and pregnancy. So what a gynecologist should know about this. So all of you will agree to me that, the moment cancer is diagnosed, maybe of any organ, the patient and the family loses their morale. Then, of course, you have to think that surgery, radiotherapy, chemotherapy, hormone therapy, and Herceptin, and so many, immunotherapy, so many things you are worried about. Fear of death is always there at the background. So as the breast cancer risk, as you have heard Dr. Alpesh Gandhi saying, the incidence is rising. The incidence is rising in younger women. And of course, our women, they are trying to delay their marriages. They're trying to delay their childbearing, which is one of the very high risk factors for breast cancer. And that is why we are nowadays dealing with such kinds of cases more and more. So rather than making a theoretical discussion or a talk, I would take you through this case. You have this 32-year-old nulliparous woman. One day she notices a lump in her left breast around a month ago. That is painless. And when you examine, you find that there is a vague irregular lump in the left breast with irregular outline, non-tender, hard in consistency. It is not fixed to the skin or the underlying structures as well. It is there's no nipple discharge and there is no lymph nodes palpable. Right breast was absolutely fine. So what is your probable diagnosis? Clinically, of course, as you can see, the vague irregular lump, so it is probably a malignancy. But then you have to follow the triple assessment or triple algorithm. The history, clinical examination, secondly, the imaging, and thirdly, of course, the tissue diagnosis. So history and clinical examination is, the delayed marriage and delayed childbearing, suggestive of, which is putting her at very high risk for breast cancer. Clinical examination is suggestive of breast cancer. You do her tissue imaging, you find that, nowadays young girl, the sonography is supposed to be better in the younger women and with the dense breast. So sonomammography gives you the optimum results. So you combine both. Then it comes to ultimately the tissue diagnosis. So you have to diagnose this with the core biopsy. MRI is not required, in a routine situations. You have this young girl whom you suspect malignancy. Now, for such women, what treatment you want to do? Naturally, because it's a very early breast cancer, that is, you define it as, before 2A stage. So early breast cancer, that gives you an indication that you have two options. Maybe you want to eradicate the disease and remove the breast, that is radical surgery. But for this lady, you can think of conservative surgery. And with this conservative surgery, you can send the tissue for histopathological examination, for ER/PR status, and HER to HER2 status. Post-operatively, of course, you have to, whether it is radical or conservative breast surgery, it has to be accompanied by radiotherapy because you are doing it only local excision, and radiotherapy has to be done. According to the results of ER/PR, maybe she needs the hormone therapy, chemotherapy, or Herceptin if she is HER2 positive. Now, why are we thinking about the conservative surgery? What is? Because she is nulliparous. So we have lots and lots of things to be cared for. Because she's young, you have to think of the cosmesis. You have to think that she has to conceive in future, and we have to think that she should be able to breastfeed. So we have to go for what is called as oncoplasty. So oncoplasty is nothing but it's a conservative surgery of breast, and that utilizes the principles of two things: cosmesis, that is plastic surgery, and of course oncology, that is good oncological control. There should be, the patient should be disease free. She should have good prognosis, good survival and quality of life, and she should have good cosmesis. So nowadays you have that facilities to decide and go for this oncoplasty before going for even the primary surgery, or you can have the privilege or decision to go for the surgery at a second stage. That is the patient and relatives and the doctor's decision. So you have various types of oncoplastic surgery, which the oncosurgeon will discuss. I will not go into this topic, But this young lady who has undergone some surgery, that is the breast conservative surgery, radiotherapy, and chemotherapy, of course, whether this patient can conceive after the treatment. The question is whether she can conceive. Yes, she can conceive, but she may not be able to conceive also. That you have to keep it in mind, because the chemotherapy can sometimes lead to infertility, though it may be just transient or sometimes even permanent. So you have to keep this in mind that,
Sneha,
yes.
you please make it full screen. It's not full screen.
Is it? Okay.
Yeah.
Is it now?
Yes.
I'm so
Now
sorry.
it's clear.
I'm so sorry. So can she conceive? Yes, she can. But sometimes because of chemotherapy, it can damage the ovaries and it can lead to transient or permanent infertility. And this you have to keep it in mind and you have to explain it to the patient and relatives in advance. So that means you have to give them the option. And of course, you have to involve the ART consultant in right from before starting any sort of treatment for this patient. So if for the conservative for the conservation of fertility, you may have to conserve the oocyte, the gamete preservation and cryotherapy you have to go for. So though most of the breast cancer, they are in the later age group, as we have said, but we are facing more and more of the younger age group. So we have to discuss this with the patient relatives, whether they have a desire to conceive after this, and if yes, then we have to include the ART consultant, go for gamete preservation, and then start the definitive therapy. So as all of you know, estrogen is the culprit for breast cancer, but it has been said and proven beyond doubt, pregnancy, breastfeeding, these are the two conditions where you have very high levels of estrogen, but they have not led to increase in the risk of recurrence. That is what has been proven beyond doubt. So she can conceive, provided you have to take adequate care, and of course you have to do counseling and you have to involve the ART consultant. Now, when should she conceive after the breast cancer? So the simple answer is at least 2 years after the completion of the treatment, the patient can conceive. Now, why this is so? Because, there are two reasons. One is depending upon the stage of the disease, the type of the disease, and, the grade, whether it is highly anaplastics, all these things, will decide, and also the patient's response. All these factors will decide whether this lady or this woman is going to have the cure of this disease. Maybe some women may take little longer, or some may, be privileged to be cured of with the shorter treatment as well. But this will vary according to these various factors. So you have to take into consideration that this treatment can vary from months to years together, and the chance of recurrence is very high during first 2 years after completion of the treatment. And that is the very reason the woman should be advised to conceive or try for conception only 2 years after completion of the treatment. So meanwhile, what should she use? Because she has to use some definitive measures of contraception. Otherwise, she may land up into termination of pregnancy. Unintended pregnancy. So barrier methods can be used, but as all of you know, it can lead to failure. Intrauterine contraceptive devices are advisable. As you know that, as follow-up therapy for breast cancer, tamoxifen is advised, and tamoxifen is a culprit which can lead to endometrial hyperplasia and malignancy. And so if at all these women should be advised any contraceptives, so it is not combined oral contraceptives, but progesterone only pills, or maybe hormonal contraceptives, that is mainly, the LNG IUS, what we can say, or it can be injectable contraceptives, which is a progesterone only contraceptive as per the MEC criterion. Now, what precautions should be taken during ovulation inductions? So once the patient has completed her safe period, that the period where now she can conceive, that is 2 years after completion of the treatment, during that period, she has used a safe contraception and now she's free of the disease. She wants to conceive. So what precautions should be taken, whether she should be allowed to conceive naturally? Yes, definitely. But at least 2 to 3 cycles, we may allow her. But such women may take little longer, and that's a very reason, considering her age, we have to start her on ovulation induction. Now, the ovulation inducing agent should be such that, they are associated with minimal complications, but with the optimum chance for successful conception. The ART consultant, as we have already discussed, that should be able to individualize the case and guide. If at all she has gone for the gamete preservation, maybe we can take help of the ART consultant and go for IVF. Now, what If at all she conceives, what precautions should be taken during pregnancy? So as an obstetrician, what we have to advise her that regular antenatal care, that is a rule for everybody, whether she has suffered from any disease or not, but regular antenatal care, routine investigations, what we have been advising for the mother and baby, and of course, monitoring for the signs of recurrence and any complications. Regular checkup of, not only the obstetrician, but also the oncologist, because oncologist is the one who will pick up the recurrence at the earliest. Imaging as per recommendation of the healthcare providers. During pregnancy, all of you will say that, yes, we should not go for, all these imaging techniques, but whenever is necessary, the safer ways for imaging, we can use it for diagnosis or early detection of the recurrence. Now, once she, delivers, can she breastfeed? Definitely. If, it's not that removal of that particular part of the breast will stop her from breastfeeding or even lactation. She will definitely have breast secretions and she can definitely breastfeed a baby. And as I have already discussed that it's not going to increase the risk of recurrence for breast cancer. So we need not worry about this. If the opposite breast is unaffected, of course, she can also do the breastfeeding completely. So as an obstetrician, I think we need to, obstetrician gynecologist, I would say, that we need to know at least these basic things. And definitely, once this patient who has been treated for breast cancer, she has completed her treatment, and when she conceives, definitely, as I have told you, that she has to consult the oncologist as well, which I'm sure Dr. Geeta will discuss in depth. So from this forum, the message to be given is that every obstetrician gynecologist has the window of opportunity to examine whether you know that the patient has suffered breast cancer already or no. As a routine, you make a habit of examining the breast. If at all you find any abnormality, you subject her for further investigations and go for evaluation and early diagnosis, and appropriate and timely referred to the oncosurgeon, breast surgeon, or maybe, the appropriate person. If you don't find any abnormality, just teach the lady self-breast examination and ask her to report to you if at all you have any problem. So with this, I would, stop my short sharing screen and, end my presentation here. And definitely, I'm eager to listen to Dr. Geeta also, what advice, especially during pregnancy, and what investigations, how we can follow this patient. So looking forward for the next talk also. Thank you so much, Dr. Asha, for the opportunity to talk on this subject. And thank you, chairpersons, for your kind introduction. And of course, I'm eager to reply to some of your queries if at all there. Thank you.
Thank you, Dr. Sneha. Over to you, Manonmani ma'am, Geeta ma'am, over to you.
Yeah, thank you, Dr. Sneha ma'am. That was a wonderful presentation, and actually I've answered so many normal day-to-day queries what as an obstetrician gynecologist we are going to have. So that was a wonderful elucidation of the breast cancer and pregnancy and how long to wait, and what about the fears about breastfeeding and all those things. Thank you, and best wishes for your candidature, and best wishes for Dr. Asha also for your candidature.
Thank you so much, madam. Thank you.
Dr. Geeta ma'am, you want to say something?
No, it was very nice, crisp, informative talk. Thank you so much, madam. Thank you, Asha madam. Thank you.
Thank you.
Thank you,
so
Dr.
much,
Geeta. Thank you.
Thank you for the opportunity too. Thank you.
Fesi sir, you are still here, so if you want to say something.
No, it's okay. It's okay. It was well covered. Everything is well covered. I think the common doubts, I think almost all covered. I think we are not seeing any questions also. Chairpersons, please carry on.
Thank you. Thank you, Dr. Fesi.
Over to you, Dr. Sujaya.
Yeah, yes, ma'am. So coming to the next session, the chairperson for the next session, we have Dr. Lohita. He's a senior specialist, District Hospital, Chikmagalur. He's been practicing obstetrics and gynecology for the last 26 years. He's published papers on evaluation and histopathological correlation of abnormal uterine bleeding in menopausal transition in a tertiary care center at Cheluvamba Hospital, Mysore. This was published in the International Journal of Clinical Obstetrics and Gynecology. So welcome to today's session, sir. We have Dr. Gracie Thomas with us. She's the founder and president of the Cochin Society. She's also the organizing secretary of AICOG, which was conducted in Kochi. She is a recipient of Dr. Pandit and Mrs. Shailaja Pandit Award from Foxy. She's involved in lots of social activities, especially involving empowerment of women. And she takes special interest in adolescent health education and conducts programs in schools and colleges. Welcome, ma'am. We also have Dr. Lata with us. She's the professor of obstetrics and gynecology in Basveshwara Medical College in Chitradurga. Madam's areas of interest are preventive oncology, infertility, safe motherhood. Welcome, ma'am, to today's session. I request one of you to please introduce the speaker, Dr. Geeta Nagashri, ma'am.
Lata ma'am, you have to unmute yourself.
Dr. Lata? Or,
Yes, madam. I'm
yeah,
here.
please could you introduce the speaker, please? Yeah.
Okay. Good evening, one and all. First of all, I would like to thank you all for giving the opportunity to chair the session. Thank you, Asha ma'am. Today's second topic speaker is Dr. Geeta Nagashri. She is senior consultant, surgical oncologist, and associate clinical director at Care Hospitals, Gachibowli, Hyderabad. She is the founder of Ashwin's Cancer Care Foundation, reputed to be the first formally qualified lady surgical and gynecological oncologist of the state. Dr. Geeta Nagashri is an alumnus of Guntur Medical College and completed her MD from the prestigious National Institute Jipmer, Pondicherry. She finished her super specialty degree MCH Surgical Oncology from one of India's premier National Oncology Institutes.
Ma'am, if you could say a few words about the topic, and Dr. Geeta, you may share, please. When I was reading about pregnancy and breast cancer, I found that the cancer that occurs in a pregnant woman, which presents for the first time in pregnancy, is different. So I thought that we should actually learn about it, that a cancer that comes to a pregnant woman for the first time, whether it's a normal cancer, like any other non-pregnant, or is the character different? So I requested Dr. Geeta to speak about it because she is a gynecologist who has done surgical oncology. So she is seeing best of both worlds. So I request her to take this topic, and we will have cases, and I request everyone to actually pitch in, because this is a topic that all of us find a little difficult. It's not so easy, just like any other case. So over to you, Geeta. What's any problem? Dr. Geeta? Yeah.
Dr. Geeta, we're able to see your slides, ma'am.
Yeah. Thank you, Dr. Asha, for giving me the opportunity. It's a wonderful program.
Dr. Geeta, we are all eager to listen to you.
Yeah. 1 minute.
We can see your slides, we can hear you.
Okay, you can hear me. 1 minute. It's not going forward.
At the bottom of your screen, there is a right arrow. That is what you need to click.
1 minute.
Slide 1 of 34 and click on that arrow.
1 minute. This something is coming. I can misclick. Call myself up. Chinna Gannu.
Ma'am, we just give ma'am some time. I think she'll get it sorted.
Okay.
Not everyone is tech savvy, ma'am. People need to get acclimatized.
Actually, it started. I also started with my son helping me in everything.
Yeah, so we all need help to guide us, ma'am.
Yeah.
ఇప్పుడు షేర్ రావట్లేదు ఇది ఓకే చాలా ఇక్కడే ఉండు yeah already it was so much discussed on this topic. Why it is important to discuss this topic? Because it's the most common cancer in the women now, and most common cancer in the pregnancy also. Normally we are seeing 1 in 28 women suffering from breast cancer. That too in Indian scenario, most of the women are 70% of the women are coming in the late stage, third stage or fourth stage to us. And compared to West, in US survival is more than 90-95%, 5-year survival rate. Even in China, it is 80%, but in India, it's still 50%. The reason being lack of awareness and negligence in the part of Indian women to come to consult their doctor. And that means every 2 women diagnosed of breast cancer, we are losing 1 woman of this of breast cancer. This is a very pathetic stage because the woman is in the, and the most important thing in Indian breast cancer in Indian women is we are having engaged breast cancers more. Average incidence of breast cancer in India is 40 to 50, whereas in the West is 50 to 60. We compared to the West, we have average incidence 10 years less. And younger the age, the tumors are more aggressive. We find more triple negative and more aggressive tumors. And 30%, more than 30% of breast cancers are less than 40 years of age. We consider our screening after 40, but more 30% now we are seeing less than 40 years of age. And being in India also, because of the career and all, they are delaying their pregnancy, late marriages and late pregnancy. We are finding more and more women with diagnosis of breast cancer in pregnancy. So breast cancer is one of the most common cancers encountered during pregnancy, and hence it is imperative to evaluate every lump thoroughly with the suspicion unless proved otherwise. Of these breast lumps also, only 20% are maybe cancers, other 80% are benign only. But every lump we should see with the suspicion unless proved otherwise. It is incumbent upon every obstetrician to diagnose and treat as early as possible without any delay. As we know, the earlier the diagnosis, the prognosis will be, survival rate and prognosis will be better. Any delay will have significant impact on the prognosis. So there is a lot of things when we find a breast lump in the pregnant woman. In our mind, we have a lot of things going around as a doctor, as an obstetrician, as an oncologist. We have a lot of, is pregnancy, so many doubts. Is pregnancy protective against breast cancer? Does pregnancy associated breast cancer carry a worse prognosis than the breast cancer that is unrelated to pregnancy? Is it a must to terminate pregnancy if breast cancer is diagnosed? What is the preferred diagnostic imaging to assess the spread of breast cancer in pregnancy? What are the modalities of treatment that can be used? Can the woman who has a breast cancer lactate? All these things, everybody has doubts. I will try to give the spotlight on the following issues. Risk factors of breast cancer, which is related to the reproduction, management of pregnancy associated with breast cancer, clinical presentation, imaging, histological diagnosis, which is very important, treatment, antenatal care, breastfeeding, contraception, everything is very important, and pregnancy after treatment of breast cancer. So what are the risk factors? Why once upon a time this breast cancer is also a disease of the West? Our Indian women is not having so many, this much incidence of breast cancer. In 1 or 2 generations before us, we are not finding so many breast cancers. Now, because everything has changed, early menopause, late menopause, late age of first pregnancy, nulliparity, and of course, the hereditary breast cancer, who the families who are carrying BRCA1, BRCA2 genes, definitely the aggressive cancers, they occur in younger age only. Breastfeeding confirmed. People say that we have people in a myth that I have breastfed my children, I don't get breast cancer. That's not breast cancer. Breastfeeding for prolonged period, like more than 2 years, has definitely a positive effect on and some positive protective effect, but that nothing like that breastfeed. If you breastfeed, people has that population has that myth that I have breastfeed, I won't get the breast cancer. Pregnancy associated breast cancer, it is defined as a breast cancer diagnosed during pregnancy or up to 1 year postpartum. Only about 3% of women diagnosed with breast cancer will be pregnant. Breast cancer incidence is approximately 1 in 3,000 pregnancies. It carries similar prognosis the pregnant and non-pregnant population by stage and grade. Incidence is increasing as more women are delaying childbirth, as I already told, and lifestyle changes. Lifestyle changes are also one of the reasons, because we, as a obstetrician gynecologist, most of the you know that how the PCOS is increasing nowadays, and all this year increased hormonal exposure on the women. And future, we are going to see more of this hormone-associated cancers like breast cancer or endometrial cancer. Now itself, endometrial cancers and all, most of the people who are taking infertility treatment and engage endometrial cancers is increasing day by day, and breast cancers are also increasing. So basically, these are the lifestyle cancers only. The 32 to 38 years is the age with the highest incidence of breast cancer with pregnancy. Breast cancer can be safely diagnosed, staged, and treated during pregnancy while protecting the fetus and mother with excellent outcomes for both of them. Diagnosis delays of 2 months or longer are common in women with gestational breast cancer due to physiological changes in the breast. Women think that because of the pregnancy, these changes are happening, and they delay showing to the doctor. So this may be responsible for for the larger increased stage, higher stage, and larger size of tumor, more lymph nodes, and the stage upgradation of the stage. Breast cancer usually present as a painless lump. Occasionally, the disease can present as a bloody nipple discharge. Very rarely, inflammatory breast cancer. Women presenting with the breast lump during pregnancy should be referred to the breast specialist team. So different differential diagnosis. If we find a breast lump, these are the things we will run in our mind. It may be invasive carcinoma. It can be lactating adenoma. It can be fibroadenoma. It can be cystic disease. It can be lobular hyperplasia. It can be milk retention cyst, galactosile. It can be abscess. It can be lipoma. It can be hematoma, lymphoma. Sometimes it happens sarcomas, neuromas, tuberculosis. All these are the differential diagnosis if you have a lump in the breast. But as I told, every lump is not a cancer. Only 20% may be invasive carcinomas, rest are benign, but every lump should be viewed with the suspicion unless proved otherwise. So imaging. This helps us to characterize the lesion. Ultrasound, because at that age, ultrasound is the best thing with the experienced breast radiologist, because that is also very important. In a day-to-day practice, we are seeing many women come in the late stage, not that they have delayed by themselves. They have the imaging in their hand that they have done 2 scans before, like 6 months before, where the radiologist has given it as a benign lump. That's why it was delayed. That's why, because what they went to gynecologist, they have written the imaging. Radiologist gives a BIRAT 2, it is a benign, then what will, then the doctor say that it is normal, because based on the radiology finding, it is normal. And after 6 months, they come in advanced stage. Yesterday also, I operated one such case. So breast ultrasound by a good experienced breast radiologist is very important. It is helpful in distinguishing solid from cystic lesions of the breast. Assessment of the tumor spread. If cancer is confirmed, with the abdominal shield, we can have one mammography, that is better. If patient is not willing, MRI breast also gives a good information. Chest radiography also with the shield, abdominal shield, we can do. And liver ultrasound is good enough to assess the, mainly we do the, once we have a diagnosis of a cancer, we should start doing the metastatic workup. What are the spaces of metastatic? It is the lungs, liver, bone, and brain.
Your brain usually it will be advanced, it will be symptoms will be there. Otherwise, ultrasound is good enough to assess the liver mets and all. Chest X-ray, obviously, some big lesions we will know. And because CT scan can't be done during pregnancy. For skeletal MRI, the early stage not needed, but it is little bit lymph nodes are there. We can do skeletal MRI is preferred over technetium bone scan or X-ray computed tomography. So histological diagnosis, ultrasound guided core needle biopsy is needed, and core needle biopsy tissue diagnosis with IHC, immunohistochemistry. To know the markers, we usually do 4 markers. You may consider temporary suppression of lactation. If patient is lactating, temporary suppression of lactation with cabergoline, because when we do biopsy and lactation area, the milk fistulas or abscess may form. Histological grade, hormone receptor status is important. We usually in IHC, we do 4 markers. That is estrogen receptor marker, progesterone receptor markers, HER2/neu, human epidermal growth factor marker, receptor 2 marker, and Ki67, that is MIB index, that is proliferative index. That also will, depending on the proliferative index, because some tumors will have very less proliferative index. If node negative and tumors are having very less proliferative index like ERPR positive, HER2 negative, and Ki67 around 10% more. In most of the women, we avoid giving chemotherapy because chemotherapy is not useful. So in such cases, these 4 markers are very important for us. So treatment of the breast cancer during pregnancy. The treatment regimen used will depend on the stage of the disease, gestational age, desire to continue the pregnancy. Treatment of breast cancer should not be unnecessarily delayed because of pregnancy. Delay or refusal to undergo therapy has serious consequences on the mother. This will require approach and involvement of multidisciplinary team. That team family should be family counseling, and family should be involved, and family support is needed, and discussion with the breast surgeon, medical oncologist, obstetrician, specialized oncology nurse, radiotherapist. Everybody has a team. Multidisciplinary approach is needed once they are diagnosed with breast cancer. In normal cancer also, we do multidisciplinary approach, more so in pregnancy with breast cancer. Usually local regional control will be with surgery because radiotherapy can't be given in pregnancy. Systemic control will be with chemotherapy. So breast cancer can be done, breast surgery can be done in all stages, therapeutic. And sometimes if advanced and fungating growth, we do palliative surgery regardless of the gestational age with negligible risk to the fetus. Chemotherapy is considered to be safe when used during the 2nd and 3rd trimester. Radiotherapy is contraindicated till delivery unless life-saving or to preserve the organ. Like sometimes spinal mets are there, spinal cord compression is there. That time we can give, but not otherwise. Hormone or monoclonal antibody are not recommended during pregnancy. Hormone therapy and targeted therapy is not recommended during pregnancy or lactation. Chemopoietic growth factors can be employed to ameliorate chemotherapy-induced neutropenia can be treated with hemopoietic growth factors. So what are the types of usually modify if it is a very much away from delivery, the diagnosis of breast cancer, like in the end of 1st trimester, like more than 6 months is there, they have to go for because radiotherapy if you do breast conserving surgery, radiotherapy is a must. So in that case, we have to have a discussion with the patient's wishes, patient's desire is also very important here. Modified radical mastectomy is a standard approach for most of the cases, stage 1 and stage 2. If it is nearing the delivery, like in the end of 2nd trimester or 3rd trimester, we can do breast conserving surgery. Overall, it is not advisable in pregnant women because in only 1st trimester. It is nearing the delivery, we can do breast conserving also. However, it may be offered to women who are diagnosed in 3rd trimester or to be followed because of radiotherapy we have to give. That is the only reason. So sentinel lymph node biopsy is indicated in women who have a negative axilla on imaging while doing ultrasound. If you have a negative, we are not finding any lymph node which is abnormal. So then we can go for the sentinel lymph node biopsy. Sentinel lymph node biopsy also, we can use radioisotope scintigraphy. Means technician radioisotope dye we can use, but blue dye is not recommended in pregnancy. Axillary lymph node dissection is recommended in positive preoperative lymph nodes, or sentinel node positive. It comes are in imaging wise, if it is a positive, it looks positive, we have to go for the axillary lymph node dissection. Reconstruction is usually not recommended in the during pregnancy, because reconstruction takes lot of time. Because if 1.5 hours, if you finish a normal surgery, reconstruction takes 3 to 4 times the normal surgery. So prolonged anesthesia, which is not good during pregnancy. So reconstruction is not recommended. If patient want reconstruction later after the delivery, she can have reconstruction. Chemotherapy. Pregnancy-associated breast cancer is usually associated with invasive and high-grade lesions, making chemotherapy necessary. Not only pregnancy-associated, because of these pregnancy-associated breast, they are younger people, younger the age, as I told, aggressive the tumors are. So usually there will be invasive and high-grade tumors. They need chemotherapy. Chemotherapy may sometimes lead to preterm delivery, low birth weight, transient trachepnea to the newborn. He has been reported when the chemotherapy is administered for less than 3 weeks before delivery. So chemotherapy also, if you have a plan of delivery, we had to be we had to give chemotherapy more than 3 weeks before the delivery. So we should, and there should be gap at least 3. So a 4 to 6 month course of usually 6 to 8 cycles. We give 3 weeks cycles of chemotherapy in node positive or node negative women with tumor 1 centimeter. Now therapy depend on the, not on the size, depend on the tumor biology. So the timing of the chemotherapy is very crucial. A delay in chemotherapy of 3 weeks following surgery is thought to be more than 3 weeks, thought to be associated with significant impact on the prognosis compared with the early commencement of chemotherapy. As early as possible, better we administer the chemotherapy. Usually the drugs we use is cyclophosphamide, doxorubicin, and 5-FU is recommended. And taxanes are also can be given in pregnancy, but there's not long-term very studies, foolproof studies are not there, but taxanes can be administered in the pregnancy. Is recommended combination of drugs used in adjuvant chemotherapy regimens as in non-pregnant, as the same regimen as in non-pregnant normal breast cancer. The role of termination of pregnancy, there is a role for termination of pregnancy in any trimesters. In addition to end pregnancy, either a personal choice of the woman or couple following an extensive discussion with a multidisciplinary. That's all. It can also be considered in cases of advanced disease, like when the diagnosis itself is diagnosed in stage 4, very advanced, where the time to diagnose, survival is very short at that time, maybe. So diagnosis of breast cancer during pregnancy, early stage 1 and 1 to first trimester. First time has, as we have already discussed, algorithm has described, because long for delivery, because of we can't give radiotherapy, we can go for modified radical mastectomy and chemotherapies. The second trimester go for breast conserving surgery plus chemotherapy, after delivery radiotherapy. Same in third trimester, delivery by 34 weeks. In third trimester, if you're at least 32 weeks, it is diagnosed miss. Till that lung maturity 34 weeks, we can delay, we can deliver the patient and go for surgery or chemotherapy or radiotherapy or hormonal therapy. Late diagnosis in first trimester. In first trimester, early first trimester means sometimes early first trimester and late diagnosis we may have to consider, depending on the family wishes and doctor discussion with the doctor. And second trimester, same surgery or do surgery and go for chemotherapy. And after delivery, we can go for, because anyhow, it takes 6 months for all these things, for radiotherapy. After 28 weeks, same, deliver the baby, deliver followed by a palliative or chemotherapy or radiotherapy or hormonal therapy. So delivery, time of delivery should be individual, but preterm deliveries is usual in these pregnancy associated breast cancer. Ideal delivery should be postponed 3 weeks after the page of chemotherapy, as I already told. Administering beta is the neonatal mobility, lung maturity, to improve the lung maturity. It is worthwhile assessing placental histology after delivery in all cases, even if it appears microscopically normal, because in general, the presence of placental metastasis indicate a poor maternal prognosis. So additional ultrasound scans can be needed for fetal growth, as approximately 40% of babies will experience a low birth weight with chemotherapy, which is usually due to fetal growth restriction. Prophylactic anticoagulants is considered if breast cancer is breast surgery is performed during pregnancy or postpartum, because pregnancy is also a hypercoagulability state, and cancer increases the chance of this DVT and all. So because of to prevent pulmonary thromboembolism, better we have a prophylactic anticoagulation. Nausea and vomiting associated with the chemotherapy can be safely tackled with a serotonin antagonist. Breastfeeding. Lactation is usually contraindicated during chemotherapy, because if milk secretion is maintained throughout chemotherapy, breastfeeding can be allowed 3 to 4 weeks after some time of administration, after that dose chemo concentration from the blood decreases after 3 to 4 weeks, we can, of the last dose, we can give, they can breastfeed. There's no evidence that women who have completed treatment for breast cancer cannot breastfeed safely from the contralateral breast. So breast conserving surgery may not inhibit lactation, but radiotherapy causes fibrosis, and lactation is unlikely in the irradiated breast. Contraception, as already Madam Dr. Sneha has discussed, effective and safe methods should be used as early as possible. All hormonal containing methods should be avoided, even hormone containing IUDs. And although it may reduce the risk of endometrial abnormalities during tamoxifen therapy, further advice is required on its safety on breast cancer survivors. So it better we avoid that. Copper T IUCDs or irreversible methods, either for the woman or husband, seem logic to be used. Effect of treatment on fertility. Chemotherapy may cause premature ovarian failure. It's already discussed by Dr. Sneha. It causes premature ovarian failure depending on women's age and treatment regimen. 96% of women over 40 years of age and receive 6 or 12 cycles of CMF for breast cancer develop amenorrhea after treatment, whereas 54% of women under 40 years experienced amenorrhea that was reversible in 23%. Because older the age of breast cancer, then more common is the amenorrhea. 9% of women younger than 35 years and receiving fluorosil these normal chemotherapy develop permanent amenorrhea. Even some people who are young also develop permanent amenorrhea. There's a reason, because previous are not there, but now ART options are there. Better we engage breast cancers. We discuss all these options with the patient before itself. They are willing, better we send to the infertility consultant so that they'll take care of this. Either they stimulate and do, if partner is there, embryo preservation or oocyte preservation.
So can fertility be before treatment? Yeah, a fertility specialist incorporation and meticulous counseling and are mandatory before starting the chemotherapy. Many at times while giving chemotherapy, GnRH analogs can be given because the GnRH analogs are protective. Ovarian protection will be there. Young women which are not preserving oocytes before starting the chemotherapy, while giving chemotherapy, we can administer a GnRH analog for ovarian protection. Cryopreservation, embryo cryopreservation, oocyte cryopreservation, immature oocytes, and ovarian tissue storage is still not in this thing. And if they are not, if the premature ovarian failure occurs, so donated donor eggs. So pregnancy after treatment of breast cancer. Up to 70% of women who are affected after treatment of breast cancer will subsequently have children. Long-term survival after breast cancer does not appear to be affected by pregnancy. Women planning a pregnancy after treatment for breast cancer should consult their obstetrician, breast surgeon, and clinical oncologist. Any routine imaging should be done before trying to conceive. Women with stage 1 or 2 disease with estrogen receptor negative should differ because estrogen receptor negative, usually estrogen receptor produces hormone receptor negative and HER2 negative, triple negative, TNBC. These are the aggressive breast cancers because most of them recur in 2 to 3 years. So they should defer pregnancy for at least 2 years after treatment. Women with stage 3 disease or estrogen receptor positive disease should consider deferring pregnancy for at least 5 years after treatment, and to stop it at least 3 months before pregnancy planning. So hormone should be stopped before 3 months before pregnancy planning. So women with stage 4 disease with 5-year survival of 15% should not be encouraged to contemplate for pregnancy. So outcome of pregnancy. Women can be reassured concerning the risk of malformation in children conceived after treatment for, because many women have so many doubts that if after women or her husband or their family members may have a doubt that after the breast cancer and after all this chemotherapy, they may have the children will have that effect. They have a malformation babies, and we should reassure them. And women who are known to be breast cancer, known to hereditary breast cancer, those women in whose families this gene is running, so carriers may wish to consider now the pre-implantation genetic diagnosis we can do for BRCA, and pregnancy following breast cancer should be jointly supervised by obstetrician, gynecologist, and breast surgeon. And echocardiography should be performed during pregnancy in women at risk to detect cardiomyopathy through resting left ventricular EF, rest ventricular ejection fraction, because the drugs, adriamycin and all, is a common drug used for in chemotherapy in breast cancer. And HER2 anyhow pregnancy we won't use targeted therapy, but we should evaluate women because adriamycin, most of them have not most of them, some percentage of women have cardiomyopathy after adriamycin usage and less ejection fraction. Again, we got all these answers. Is pregnancy protective against breast cancer? Does pregnancy associated breast cancer has a worse prognosis than unrelated pregnancy? Worse prognosis only because delay in the diagnosis, not as such because it occurs in pregnancy, it is worst. Is it must to terminate pregnancy? No. What is the preferred diagnostic method? We know that usually the diagnosis, the imaging which has high radiation exposure, we usually avoid. What are the modalities of treatment? We have already discussed. When a woman have a breast cancer lactate, normally lactate, when they are using chemotherapy, they should not take every lump in the breast. Treat with high suspicion unless proved otherwise. Ultrasound breast forms, the ultrasonogram forms the first imaging, and that too with the again, and I am telling, with the experienced good radiologist. surgery and chemotherapy form the main treatment modalities during pregnancy. Termination of pregnancy does not improve the prognosis and is not recommended by NCCN guidelines anywhere in the guidelines. And even NCCN recommend against termination of pregnancy, whatever may be the trimester. Lactation is not contraindicated in the alternative breast, in the contralateral breast. Sorry, avoid hormonal contraception. A multidisciplinary approach is the way to go. Thank you.
Thank you so much, Geeta. Over to you, Dr. Lata, ma'am. You're muted, ma'am. You're muted.
Thank you, Geeta madam. You have covered almost everything regarding breast cancer and pregnancy, management, diagnosis, differential diagnosis, clinical features, everything you have covered, and you have only asked so many questions and answered that also. Thank you so much, madam.
One
Very
more thing
elaborative talk, and it was very nice.
One more thing I want to tell, madam, because you obstetricians are the first whom the ladies visit. For every woman, you should convince. I always say one thing. CMI, nowadays, you are not getting one saree or one dress less than 3,000 to 4,000. Forgo one saree or one dress per year and get this mammography screening done. But very difficult to motivate Indian women. But it is up to, if definitely their family doctor has a gynecologist, you tell, definitely they will listen and they will get it done. Actually you have now the participant may be less, but you should take it in your respective societies, this as a drive, and motivate all the doctors in this thing to get this to convince the women. This is not much cost, spending 3,000 per year and get the mammography done.
Dr. Geeta.
So,
Dr. Geeta,
Yes,
this
madam.
is Dr. Asha Jain. The participants are not less. They are not on this platform. They are all on YouTube.
No. I'm not that because I want them to take to their respective societies in a big way.
Yes.
That's
Yes,
what I want to
agreed.
convey. Sorry, and you have to
Please stop sharing. Please stop sharing. Dr. Lupita, would you like to say something, sir?
Madam, it is a very informative talk. Thank you, Dr. Geeta, madam. Thank you, Asha Jain, madam,
Stop
for
sharing.
giving the opportunity. Thank you, madam. Thank you so much.
Thank you, sir. Thank you. Dr. Geeta, do you have the time to stay for some time?
Me?
Yes, ma'am. Yes, ma'am.
Yeah, that Geeta. Okay.
Because, we have one medical oncologist, and I would really like you to stay along because, I have put the case scenarios, but even I don't know all the answers. So, with you people present, we would like to learn through the panel, through the cases. Please stop sharing so that I can share my screen.
Oh, I have to stop. Okay.
Yeah.
Yeah, I've stopped.
No, you have not stopped.
I think the screen is gone.
Now you've stopped. Thank you, Geeta.
Yeah.
So, Dr. Suman Mittal is here. She is a dear friend and a medical oncologist from Raipur. She has a huge hospital that runs only on cancer. So I'll be introducing everyone formally, but I really, this panel that I have made, it is for us to learn through your presence. So I would like to introduce my experts, Dr. Narendra Zope, who's the president of Chalisgaon, Dr. Mandar Karambekar from Chalisgaon Society. We have Dr. Suman Mittal, medical oncologist and hematologist, director Mittal Hospital, Raipur, and a very knowledgeable and very active medical oncologist, always ready to help us gynecologists. So we have Dr. Arpita Gandhi, ma'am, who is the president of Devghar Society. We have Dr. Bhavya A.B., secretary of Kannur Society. Dr. Sachin Khedkar from Khedkar Hospital, Chalisgaon. We have Dr. Lokeshwari, who is the secretary of Chitradurga Society. And Dr. Prashasti, who's completed her MBA, BS and MS from Rajiv Gandhi University of Health Sciences, Bengaluru. And she's the secretary of Chikmagalur Society. We have Kumudni Jha ma'am, a very senior gynecologist, and she is the president of Darbhanga Society. She is a person who avidly wants to learn. We have Dr. Rajshri Purbe, who is also the secretary of Darbhanga Society. Dr. Rashmi S. She has some problem. She might join in later. Past secretary of Chitradurga, Dr. Muruga Lakshmi, who's the professor gynae at Coimbatore Medical College, secretary of Kovai Society. So these are our panelists. And now I will start the panel proper. Excuse me, just a second. So it's case discussion on pregnancy and breast cancer. That's me. Sujaya has been kind enough to introduce me. I request all of you to support me. Now we come to the first case scenario. It is my request to all the panelists, please put on your videos. Otherwise, it's very difficult to interact. Please put on your videos. So this is a case scenario. A 32-year-old woman who's 18 weeks pregnant presents with a palpable breast lump. Mammography confirms a suspicious mass and subsequent biopsy reveals an invasive ductal carcinoma. So how are you going to approach the diagnosis of breast cancer in a pregnant woman? Anybody can answer. She has just been diagnosed as breast cancer. I request everyone present here to actually join in the discussion.
Very good evening, ma'am.
Yes, ma'am.
I'm Kumudini. Yeah, I just want to say a couple of lines before I start the answer. Actually, when I talked to Asha ma'am, she said, I'm a very ordinary Foxy member. So we want to first thing see you as a special Foxy member. And second thing, she's so humble, despite being so knowledgeable. She's like, a tree which has lots of fruits. That tree only bows down. So now coming to the question proper, how to diagnose the case of breast cancer in pregnant women. In pregnant women, we actually have some problem and there's a delay in the diagnosis because of the engorgement, the proliferative changes in the breast, and the cell proliferation is quite rapid in these patients. So that is why in the biopsy also, we have to tell the pathologist that she's a pregnant patient. Now we begin first with the history, whether when you see a lump and you suspect it, you have to take a history, a family history of the mother having it or the sister having it. So then you can advise a genetic analysis also simultaneously with the BRCA. And in these patients, you see what is the type of the nature of the lump, whether it is tender, non-tender. Sometimes mastitis also can masquerade as the malignancy can masquerade as mastitis. So we have to be careful about that. So you have to see whether there's a nipple retraction, whether there's a purity orange change in that. Because the patients may think,
this patient is already, now we know that she has breast cancer. She's 18 weeks pregnant. We know she's pregnant. She is having breast cancer. Okay.
So we would like to
what are you going to say to her about her pregnancy? How are you, she'll have concerns whether she should have treatment or she should continue with the pregnancy and take treatment later. So what is an obstetrician's viewpoint to this case?
So we would like to see what is her gravidity, whether she wants future fertility, what is the stage at present, what is the type of the histopathology of the cancer, and what is the trimester in which she is presenting. So in the first trimester, usually if we need we do not give chemotherapy because all the chemos get transferred into
she's
the
18 weeks. This case is 18 weeks. Now, what are we going to do with her?
Yeah, so if she's in the second trimester, then we can, of course, advise her modified radical mastectomy, and then follow it by chemotherapy. Depends on what stage it is, whether she has axillary glands also present or not, whether a sentinel lymph node biopsy is required or not. And you have to, after grading that, if you are suspecting, say there is a metastasis in that, then you have to do, you don't do a CT scan of the bone. You can just do an ultrasonography of the liver for metastasis there, or the lungs, you can do an X-ray, and you can do an MRI of the skeletal system to know whether there's metastasis or not. And depending on all these features, then you decide on the treatment with an oncologist.
Dr. Suman? Dr. Suman?
Yeah.
Would you like to
understand? Hello?
Yes, ma'am.
Am I audible?
Yeah, you're audible.
Yeah. So as one comment that why the mammography was done in the first place in a pregnant woman, because mammography, as we understand, it is a X-ray of the breast. So generally, it is not advised for patient.
It's a sonomamography. It's a sonomamography.
Yeah. So okay. So the mammography, it is like why X-ray was done for the patient. So now it's a 18 weeks, so we need to do the staging workup. We have the limitations that we cannot do X-ray, we cannot do CT scan in this patient. So we can do sonography and we can do MRI where if needed. And after diagnosis of the staging, so whether it's like stage 1, clinical stage 1, stage 2, we need to understand that, because if it is early stage disease, we can directly go ahead with the surgery. But suppose if it is an advanced phase, so let's say large primary, or if there are lymph nodes positive, so in that case, we won't be going ahead with any kind of surgery initially. We'll go ahead with the neoadjuvant chemotherapy, which is a standard of care nowadays, and in second trimester. And before that, we need to discuss with the patient about the prognosis of the disease, about the prognosis related to the pregnancy, child, delivery. We need to address all their concern. We need to address that it is the current medication protocols we have available with us. So if she wishes, she can continue with the pregnancy, and we can take care of her anytime without adversely affecting the pregnancy. At the same time, without adversely affecting her prognosis from a carcinoma point of view. So if suppose patient wishes to continue with the pregnancy, so depending upon the stage, we'll be doing either chemotherapy first followed by surgery, or we will do surgery first followed by the chemotherapy. Surgery will depend whether breast conservative surgery or MRM, depending upon the stage of the tumor. Suppose if patient do not wish to continue with the pregnancy, then still she has 2 weeks time. Patient need to act fast, decide fast, and at the same time, we as a doctor also need to act fast.
So actually, the point that I wanted to bring up here, that she has a diagnosis. So the first thing we need to do is a gynecologist, an oncologist, and somebody to help her psychologically, some family member. They should have a meeting together, and first they discuss among themselves, and then they discuss with the patient what are the options available. As Dr. Geeta's presentation just now told us, that only 7% will subsequently have a child. So if this is her first child, she wants the child, then this may be her only chance of having that child. And Dr. Geeta also brought up the data that continuing with the pregnancy does not change the prognosis. So, Dr. Geeta, if you are there, may I ask you a question, please?
Yes, please tell.
Please put on your video. I actually wanted to ask you, is there any role of sentinel node biopsy? If she has a lump, it's a palpable lump irregular, but is there any role of sentinel node biopsy, and how would you do it in a pregnant woman?
Yeah, in early stage in pregnant women where imaging is node negative by imaging wise, like it is not suspicious nodes like if nodes are there also preserved fatty hilum and all is there, not suspicious nodes, we can go for sentinel node. Biopsy it is not indicated, but blue dye is contraindicated. We had to use radionuclide dye.
Okay, so you use technetium. So does that not harm the baby?
Not my studies was not showing, like we can't have a foolproof perfect studies, but it's not much that effect won't be there.
Because if it
Like
is given into the tissue 2 hours
it is
prior,
very,
90% gets stored.
It is very small dose that what they use for this technetium dye, and that is won't spread to that area. That long area distant exposure is not there for this technetium dye.
Thank you. Thank you so much for that. So for us gynecologists, I think we need to tell our patients to conceive fast. Don't delay pregnancy beyond, 35 years. Getting married at 30, getting pregnant at 35 is not such a good idea. Now we have a 28-year-old woman who's been previously treated for stage 2 breast cancer. She is now in remission and wants to conceive. She is concerned about the potential impact of a past cancer treatment on her fertility and the risk of cancer recurrence during pregnancy. So one thing is, to any gynecologist, I would like to ask this question: how do you determine her fertility? Whether she can get pregnant or not, what are you going to do about it? How are you going to test for her fertility? Dr. Lokeshwari?
Like ovarian reserve, you had to like any other.
Yes.
Yes, ma'am. Egg site or oocyte, embryo or oocyte preservation, cryopreservation can be done.
No, not that.
Already
we need to find out whether it was done before, and if it has not been done before, we will have to find out, what is her ovarian reserve. Right?
Actually, FSH, anti-Mullerian factor, and all these we can do blood test, and ultrasound wise also you can assess, and to some extent we can know whether she's depending on the type of breast cancer, whether it is positive type, whether it is in hormonal therapy. Hormonal therapy to obviously suppress. We had to stop this hormonal therapy for some time and see. She's menstruating after chemotherapy. All these things we had to see.
Okay, so she's just 28 now. She's been treated. She got the disease quite early, and we all know that early disease is the one that is usually more aggressive. So how many...
most of the women, at least 50% of the women after chemotherapy, they don't menstruate. Maybe ovarian function may be there.
Yeah. So we need to find out what she did before, and then we need to look after her fertility concerns. So do any of you, Dr. Suman, Geeta, do you advise psychological counseling of such patients?
Yes, younger the patient, more disturbed they are. They need psychological. We, as a doctors, as a primary physicians, we have to do the counseling, and also psychological counseling by the proper psychologists we need, and also more than us and psychologists. In my observation, what will help more is the support group. Those who already got treated, if they talk, patients feel so comfortable. Support also is needed.
Definitely, not only this woman, but almost every patient who are diagnosed with cancer, they need psychological support. And younger the patient is, more the educated patients is, their psychological concerns are even more. So we definitely need to counsel them. As madam said, that we need to have certain kind of psychologists, trained psychologists, and even patient help groups. They also help a lot in such patients.
Okay. So now, the lectures have been so good that I'm just skimming through the different case scenes. So there's a 35-year-old woman. She's 28 weeks pregnant. She now has been diagnosed with breast cancer, but she also gets gestational diabetes and she also gets pregnancy-induced hypertension. Now, what are you going to do with this patient? Do you want to deliver her preterm? Means what are you going to do with her? What are you worried about more?
Should I?
Who is answering? Yes, please.
Yeah. So, 35-year-old woman, she's only 28 weeks. So here that we need to continue the pregnancy. Now we have to manage her pregnancy-related complication as usual. Along the same time, we need to start treatment for her carcinoma breast. So what exact treatment we are going to plan will depend upon her stage of the carcinoma breast. So if it is early breast, so treatment will be same as we will be treating a non-pregnant woman.
What, Dr. Suman, my question is that what are you going to prioritize? Are you going to prioritize gestational diabetes or PIH? And does diabetes make the prognosis worse in cancer?
No.
Is there any relation?
No.
That is what we want from you, that even if she gets gestational diabetes, it's not going to worsen her cancer.
It's not going to worsen the
And if she has PIH at 28 weeks, then we will have to, deliver her as per the Doppler and the condition of the baby, because PIH by itself is something that will cause preterm delivery.
Yeah.
Arpita,
So
would you like to say
delivery
anything about this?
So delivery decision should be as per the obstetric indication, and because pregnancy, carcinoma breast is not going to affect her delivery, so we would like to get it done as per obstetric indication. So it's better to have more mature baby as much as possible, as our gynecologist colleague always does.
Okay, because there would be the stress of cancer. There would also be the stress of diabetes and PIH. All that may cause preterm labor by itself.
Yes.
And then would the treatment of that cancer differ? Means, supposing she delivers at 32 weeks. We've dealt with her obstetrically. We've given her steroid. We've given her neuroprotection. She's delivered. Okay. So does this treatment differ from a non-pregnant patient of cancer?
No, the basic chemotherapy remains the same. The only thing is we generally want to stop chemotherapy 3 weeks before the expected date.
Okay.
So just
your voice is breaking, Dr. Suman. Your voice is gone.
And we will do it.
Hello. Can I ask a question?
Yes, Mumati ma'am.
If supposing she has to be delivered because of PIH or diabetes, whatever obstetrical reasons, say at 32 or 34 weeks, and she's already running on chemo, and she delivers within 3 weeks of the stoppage of the chemo, then there'll be severe problems of neutropenia in these patients and in the babies. So how do you manage it? By GSF? Is that going to help?
Yeah, that's going to help. That is definitely going to help. And ma'am, while the patient is on chemotherapy, how are you going to monitor the baby? What are our monitoring strategies? As obstetricians, how are we going to monitor this baby?
We have to invite the neonatologist into the loop, and we have to do a cardiac assessment of the baby, as well as the mother if she has been on anthracyclines, and because that leads to cardiomyopathy. And the baby has to be in the NICU because there are chances if the baby is preterm. Because of that, as it is, it will have its own complications. And in addition to that, because of the effects of chemotherapy. It has been seen that in the long-term study, like autotoxicity has to be checked for when platinum has been given. And in these anthracycline patients, they have to check for neonatal echo. In the long term also, they have been seen to have low IQ and visuospatial problems. And they are unable to handle emotional stress. That also has been seen in the long run follow-up.
Thank you, ma'am. Thank you so much. Dr. Suman, Dr. Geeta, your babies of your pregnant women who had cancer, have you noted any of these changes that they are, psychologically not so mature, or there is autotoxicity? Anyone with chemotherapy, may not be breast cancer. All of them have disappeared. So we go to the next case. She is 40 years old. She is 14 weeks pregnant and presents with breast changes, including nipple discharge and skin dimpling, which she attributes to pregnancy-related hormonal changes. Breast cancer is diagnosed at a later stage due to delayed evaluation of symptoms. So when you are examining your patient, how would you differentiate pregnancy-related changes from changes of some other problem? Dr. Lokeshwari? Dr. Lokeshwari, want to say something?
Routinely, we do breast examination in all ANC cases.
Yeah.
Usually, with pregnancy, the physiological changes itself will cause engorgement and proliferation of the tissues now. So usually, it is difficult to say. To diagnose. This makes us very challenging, ma'am, to differentiate between the cancer and the physiological changes.
Is there some problem you want to put on your video?
Yes, ma'am.
Means I find it easier to communicate.
Yes.
Dr. Geeta, please put on your video. Yeah, please. So, anything else that, Geeta, you would like to tell us that, this is the kind of lump where you should be more alert about?
Definitely, there is a delay in diagnosis of breast cancer in pregnancy
a
because
woman has come with breast changes. So
yes.
what do you want us to examine to rule out cancer? That this looks normal and this is not normal, evaluate further.
Usually the changes mimic the normal changes in physiological changes in pregnancy. That's why they are delaying the diagnosis and they come mostly in the late stage only, at least compared to the normal this thing. As such in India, normal women also, they come late only, the diagnosis. So, and even so in pregnancy, because of they think it is a pregnancy changes and they ask their relatives or friends that they tell that it happened for me also during pregnancy. Then they delay. They won't consult doctors.
So,
they
Dr. Geeta,
just consult their own.
I'm asking you a different question.
Yes, I understood.
The woman has already come to you.
Yes,
How
yes.
will you examine?
Yeah,
and differentiate.
We see certain any lumps, any nipple retraction, any discharge, blood change discharge from the nipple, or any lumps in the axilla, or any changes which we are not finding normal. We should consider. We should at least minimum. We had to go for ultrasound test with the experienced radiologist.
Okay, thank you. And now this is for our gynecologist, that there's a 30-year-old breast cancer survivor. She is in remission. She gives birth and doesn't know whether to breastfeed or not. She is taking adjuvant therapy. So probably she's taking letrozole or tamoxifen. So do you want her to breastfeed or not?
Yes, ma'am. Yes, she can breastfeed. Yes, ma'am, she can breastfeed. There may be difficulty due to the scar in that breast. But if her other breast is okay, she can breastfeed from that breast also. And from that, the one which has been operated, she can breastfeed from that breast also.
Okay. Thank you. Thank you. So now there's another case where she's 12 weeks. and she has a recurrence of her breast cancer. She had treatment 5 years back for early stage cancer. Now she has come at 12 weeks with recurrent breast cancer. So, Dr. Geeta, can you give her chemotherapy?
Yes, she's 12 weeks pregnant, no?
Yeah.
Yeah, we can. First trimester is almost going to over. We can give chemotherapy. We had to do again the biopsy of the recurrent site, and initially it may be hormone positive. Sometimes in the recurrence it may change. It may be hormone negative. Initially it can be negative. It can be positive. There's a change. Biopsy is compulsory. Though imaging or any scan is showing it looks like recurrence. Imaging is compulsory. After not imaging, biopsy is compulsory. Biopsy and IHC for the hormone receptors, and afterwards, depending on that, we can go for the chemotherapy.
Okay, so
targeted therapy
one
and
question that I want to ask
in the pregnancy.
One thing that I want to know, that in recurrent cancer, what is your treatment protocol?
Recurrent cancer also same protocol has in normal patient. We have to go for the chemotherapy. Chemotherapy.
Surgery or radiotherapy?
Radiotherapy in pregnancy, we should avoid radiotherapy.
Okay.
Only chemotherapy can be given. Usually surgery means a surgery only, usually recurrence means usually it will be distal recurrence, metastasis only. If it is a local recurrence and small after breast conserving same place, some lesion is there, that we can go for surgery. But if it is a distal metastasis, we have to go for chemotherapy only.
Okay. So now this is another thing, that there's a 34-year-old lady, she's 10 weeks pregnant. She said her mother gets cancer, so she gets her BRCA done and it is positive. Now she is worried that because of my pregnancy, I will get breast cancer. So is there a connection between pregnancy and breast cancer?
No.
So these are the questions.
The chance of you getting the breast cancer.
Huh?
It won't increase for her chance of getting breast cancer, more chance of getting breast cancer. It's like any other normal woman.
Okay. So now this is a 37-year-old, 24 weeks pregnant, and she presents with metastatic breast cancer, which is confirmed by imaging and biopsy. It has gone to the liver and bones. She is 24 weeks. What are you going to do for her?
24 weeks pregnancy, because it is a metastatic breast cancer, she has to go for a chemotherapy.
Okay. So, Kumudni ma'am,
Yes, ma'am.
Are you worried about that baby? The life expectancy of the patient, how long she's going to live?
Yes, these recurrent cancers, if there is pregnancy, then usually it has been seen the prognosis is not generally good. And because the life expectancy is less, with considering that also, many patients may not want to, of course, this is 24 weeks, but if she's in an earlier pregnancy, she may want to terminate.
No, but now she's 24. So
yeah,
what
so she'll continue with that.
Going to be?
She will continue with that. But then on the recurrent breast cancers, usually the life expectancy is much less than it would be de novo.
Dr. Lokeshwari, you want to add something?
Ma'am, actually, it's better to, because it is a metastatic disease, better we can go for termination, ma'am. Because in last stage 4 and metastatic disease has very bad prognosis, and there is no effect on the long survival rate. Better go for termination.
No, but what will your termination achieve?
Ma'am?
What will your termination achieve? The pregnancy does not change the course of treatment, right? And the treatment does not really affect the pregnancy. So why do you want to terminate?
Usually it is said in late stage diseases and recurrent disease, usually we don't advise to continue the pregnancy. Usually pregnancy is deferred.
No, she's already 24 weeks. Now she's got a recurrence. Dr. Geeta, you want to say something? You're muted.
You can't terminate at least this stage because 24 weeks, but depends if patient family insists for termination. That's the only reason we can terminate the pregnancy. Sometimes we don't know, family wants termination because if a mother dies, nobody to look after the baby. It is the family wish. That there is no medical reason. Like as a doctors, we should not advise her for 24 weeks, and it won't affect the treatment. Chemotherapy can be continued.
So I think that is a big take home point, that it is the family's decision. It's the they have to decide what they want. A counseling session here is mandatory. There is no medical reason to advise termination. So we cannot give radiation. These are all the charts that I have. And as a summary, before this, I would like take home messages first from our panelists and then from our experts. Geeta, you go last.
The first thing I would like to say is we have to teach each and every patient self-breast examination, because that is one thing which can help us to diagnose the carcinoma early if it is there. And the prognosis depends on the stage of the disease. So it is very essential that we examine each and every patient, be it antenatal, be it gynecology. And we have to tell them that after every menstruation, you should palpate with the flat of your hand and see whether there's any discharge, any retraction, or is in a lump, then please come over. And we should investigate that to rule out the carcinoma. If it is not there, fine. Otherwise, we are missing out on a big thing.
Thank you, ma'am. Arpita, ma'am?
Yeah, Asma ma'am, first of all, I will like to ask myself only, because after Corona, I'm seeing that very many of the gynecologists, they are not doing pelvic examination. Breast examination is also left. It is our duty, it is my responsibility to examine from pediatric to geriatric. Examination of breast is a must, because whether she is coming at the age of 5 or at the age of 85, we must do the examination. And those patients who are coming for their first antenatal checkup, we must do thorough breast examination for sign of pregnancy, whether she is pregnant or not, and breast changes. And above that, if she is having any lump, we should tell her that, look, the lump is there, you should get it investigated.
So that was a very big point, ma'am, that we need to examine our patients.
Yeah.
That is something we always miss. That is a very big thing.
Yeah.
A very big take-home message for all us gynecologists. Please examine the breast and the pelvis.
Yeah. Just to avoid these two cancers, carcinoma cervix and carcinoma breast. Because very recently, I have come across a patient. She is daughter of a renowned physician. I was treating her for infertility, and there was a breast lump, and her maternal uncle is a surgeon. She said, "Madam, मैंने तो FNSC करा लिया, सब ठीक है." She again became pregnant, and I did cesarean section on 20th of February, and on 20th January, her mother was diagnosed to have third stage carcinoma breast. Name of that doctor is, he is a very famous doctor of Devghar, Dr. Sikandar Singh, his wife, and they are very reluctant. Nahi, kuch nahi hoga, maine to FNSC kara liya. And on her discharge paper, I have written in red bold letters that get your breast examined, get your BRCA done, and then you come to me.
Thank you, ma'am. Lokeshwari, Dr. Lokeshwari?
Yes,
one point from you.
Ma'am, apart from breast self-examination, one more thing, important thing, we have to create the awareness for the public. Like if they find any abnormality in their breast, better it's early to consult the doctors as early as possible. That is also important, I think.
Awareness is very important. Dr. Lata, you are still there. Would you like to say something? Dr. Lata and Dr. Geeta?
Yes.
Yes, ma'am. Go ahead. No, not you, Geeta. Dr. Geeta Mekoth and Dr. Lata. Geeta Mekoth, ma'am?
Yes, ma'am, there.
Just anything, your takeaway from today's webinar?
Self-breast examination, madam. Can we teach it staff? Ask the staff in our OP to just examine the breast. If they, in case the gynecologists are busy, at least that we can do, no?
Okay. Okay. Agreed. Dr. Geeta Nagashri. Yes, Geeta, over to you.
Yeah, I request all the gynecologists who is attending this to just to motivate whoever come to your OPD, get these screening tests done, and their attenders also you motivate and ask them to motivate 10 more their relatives, their friends and all. As I told, no, it is not like it is less than one saree or cost of one dress. You just tell them that and motivate, because to see millions or trillions of money is going into research for breast cancer. The most research is going on only in the breast cancer. They spend lot of money, but whatever it may be, year by year, every 6 months, every 3 months, new drug will come. But whatever it may be, early diagnosis is the key to success, key to good prognosis, key to long-term survival. Just I tell my patient, by the time you have to get palpate by your hand, it should be at least 2 centimeters size, like a cherry size or a amla size. But you tell them that, but in mammography, you will find in the rye mustard seed size in millimeters. Then they don't a difference, like where is mustard seed and where is cherry. So at least we should motivate them and get them these tests every year. Because if you motivate them 1 year, they think and they won't do again. So every year we should teach them that. That's the only way we can achieve a better survival. Because in China and Korea also is like India only. They also don't have a population-based screening, but they have achieved 80% survival, where we are stuck up at 50% only still, because they achieved only by this advocacy. One by one, advocacy, word of mouth and advocacy, only they achieved that 80% survival. I hope if we all gynecologists together, if all lady doctors together, if you do, we will also rise our 5-year survival rate. I wish and hope and pray that it will happen, because it is very hard, very distressing to see women coming in that when their productive years of life, when the family is young and all, coming with advanced stage, third stage and fourth stage, and they are all well educated. I have seen ministers' wives, IAS officers, doctors coming in late stages.
Lata ma'am, would you like to say something?
Yes, madam.
Yes,
like we should concentrate also on preventive aspect, promotion of lactation. That is very, very important. Breastfeeding, prolonged breastfeeding, at least for minimum 2 years. For that, we should insist for all mothers. At least for minimum 2 years, they have to breastfeed the baby, which has got a protective effect on prevention of breast cancer. That is one thing.
Is very little. The protective effect is very
little.
Very little. It's not even significant. And in our country, if a woman breastfeeds for 2 years, the baby gets nutritionally deficient.
And madam was telling, some doctor, they told that they did FNSC and told that nothing is there. Everybody will have that denial effect that, oh, no, it won't happen for me. It will happen for others. That is the way everybody thinks. There's a reason. Not that they don't know this, something like this is there. The denial thing is doing that.
Dr. Geeta Khanna, ma'am, you are here. Dr. Manisha Agarwal is also here. If you want to say something, ma'am, you can say it.
Madam, yeah, just one thing. We have done, madam, we have done mammogram for all the gynecologists in Kannur.
Great. Very great.
And perhaps this thing also at HPV DNA for all the members of the society.
Dr. Sujaya, your take now.
Ma'am, nothing as no, actually, I was listening as Dr. Geeta Nagashri ma'am was endorsing repeatedly. We have to do screening for all the women who come or walk into our OP. I think we have to sensitize everyone to it. So it was a very good talk, ma'am. I hope the audience could benefit.
So I think, Geeta ma'am, Dr. Manisha, if you want to say something, otherwise I would officially thank everyone and end the session. Nobody wants to say something. So namaskar. Thank you very much for being here and spending the evening with us.
Thank you, ma'am. Thank you.
I learned a lot reading for this, and the Geeta has been kind enough. On one phone call, she agreed to, speak on this topic and stay on so that we could really learn. Thank you, Geeta. Thank you.
Thank you so much, ma'am. This was an excellent
Yeah,
moderation.
and last but not the least, ma'am, we would like to ask everyone who's logged in today for support for Madam's candidature for food and drug. So please support ma'am. As you've seen, she's a very good academician and orator. So she will do a lot for the society. So kindly support ma'am.
Surely.
Yes, not only me, my whole Devgarh society is going to support her.
Thank you, ma'am. Thank you so much, ma'am.
Canvas Society will also support.
Thank you.
Thank you, ma'am. This
Thank
was
you.
an excellent moderation and we learned a lot.
Thank you. Namaskar, Shubhratri. Dr. Mars, you may end the session, please.
Okay, thank you, ma'am. Thank you.
Thank you, Walter
Thank you.
Bushell, for being my academic partners.
Thank you. Thanks.